Welcome back to the deep dive. So today we're tackling a topic that I think for any medical learner, especially in those first couple of years, can feel, well, just massive.
Absolutely. Gastroenterology.
Yeah, it's just so intricate, so high stakes, and frankly, a bit overwhelming. The volume of information in a text like Davidson's is huge.
It truly is. It's an entire ecosystem, really. I mean, we're talking about this single complex tube stretching from the mouth all the way to the anus, but it's responsible for so much more than just digestion.
Like regulating immunity, hormone production.
Exactly. So for those of you leaning on Davidson's to build that core clinical knowledge, the GI section can be pretty dense.
Absolutely. So our goal here isn't just to read you the chapter. Our mission is to give you a kind of high-yield anchor map.
A curated cheat sheet.
A cheat sheet, yeah, designed to speed up your understanding and, maybe more importantly, your long-term retention of this stuff. We're distilling the most critical concepts, the classic clinical patterns, and the tools you'll actually use.
And we're going to do that using some memorable anchors and metaphors to make these complex processes stick. Everything we're discussing is built right out of Davidson's, covering the whole system: esophagus, stomach, bowel, colon, pancreas.
So think of this as your expert guide. We're not just telling you what the facts are, but really digging into why they matter at the bedside.
Okay, let's start at the very beginning with how this whole system actually works, its function, and its control.
Right. Let's start at the top of the tract with some foundational anatomy. I think we often overlook the intense mechanical choreography that's just required to move food through the system.
It's like the original assembly line, isn't it? But running in reverse, it's for disassembly and absorption. And the machinery is so different depending on where you are.
So our first key anchor for the esophagus, let's think of it as the muscular slide. It's this muscular tube about 25 centimeters long that runs from the cricoid cartilage in your neck right down to the stomach's cardiac orifice.
And that's about 40 centimeters from the incisors, which is a key measurement for endoscopy.
All right. And that slide isn't just a passive drop, is it?
Not at all. It's highly regulated. You've got the upper esophageal sphincter at the top, keeping air out, and then the really important lower esophageal sphincter, the LES, acting as a valve to stop reflux.
And the movement itself.
That's a primary peristaltic wave. It's this coordinated muscular contraction that's controlled directly by the brainstem. And if that neural control fails, that's when you get into major motility disorders like achalasia.
Which makes the transition to the next stop, the stomach and duodenum, even more critical. The stomach isn't just a simple holding bag. We're anchoring it as the hopper.
The hopper analogy is perfect. Its job is to hold food, yes, but it's also about intense mechanical grinding and chemical mixing.
And crucially, it doesn't just dump everything at once.
No, absolutely not. It actively propels these small, controlled amounts of chyme into the duodenum through the pylorus. And that controlled release is vital because the duodenum is basically the orchestra conductor for the entire downstream digestive process.
Which brings us right to the chemical factory part of the stomach's job. Acid secretion.
Yeah, this is paramount. The gastric parietal cell is the star of the show here.
Okay, so what drives it?
The key stimulants are gastrin, which is a hormone, histamine acting locally, and acetylcholine from nerve endings. All three of those converge to activate the final effector.
The proton pump.
The proton pump, that's the hydrogen-potassium ATPase. It actively pumps hydrogen ions out of the cell and into the stomach lumen in exchange for potassium.
So that's the mechanism. But for a student trying to remember this, what are the three big reasons for generating all that acid?
Great question. The functions are non-negotiable for survival. First, it sterilizes the GI tract. It kills the vast majority of pathogens you swallow.
Okay, that makes sense.
Second, it's essential for protein digestion. It converts pepsinogen, which is secreted by chief cells, into its active form, pepsin.
And the third?
The third is that, in parallel with acid, those same parietal cells also secrete a glycoprotein called intrinsic factor.
For B12 absorption.
Yeah, exactly. And it's an absolute requirement for absorbing vitamin B12 way down in the terminal ileum. So any pathology that hits the parietal cells, like autoimmune gastritis, is going to impact all three of those functions.
That makes the whole process of B12 absorption seem so vulnerable to what happens way, way earlier in the tract. Okay, moving downstream. Probably the most complicated logistical task the GI tract faces is absorbing fat.
It really is.
It's a multi-step, multi-phase process with molecules that don't like water. So we anchor this whole section as the micelle taxi service.
The difficulty is all about immiscibility. Lipids are hydrophobic, but the small intestine is an aqueous, a watery environment. The body has to create this super efficient water-soluble transport system to get fat from the lumen across the mucosa and into the circulation.
Okay, so let's walk our learners through the 6 essential steps.
Yeah.
Step 1 is the signal.
Right. When dietary fat enters the duodenum, that's the luminal phase, it acts as a really potent signal telling the mucosal cells to release cholecystokin or CCK.
Step 2. CCK becomes the orchestrator.
The master orchestrator. It gets into the bloodstream and triggers 2 vital simultaneous actions. It makes the gallbladder contract, releasing all that stored bile.
And it tells the pancreas to release its enzymes.
Crucially, lipase and collapase. It also relaxes the sphincter of Oddi so everything can get into the duodenum.
Okay, step 3. This is where the anchor comes to life. The taxi formation.
Exactly. So you have bile acids and salts, which are amphipathic. They have a water-loving end and a fat-loving end. They combine with all the products of fat digestion, fatty acids, cholesterol, fat-soluble vitamins A, D, E, K.
And they form these little packages.
They form mixed micelles. These are our taxis. They wrap up all the non-soluble cargo and make it soluble enough to travel through that watery environment.
So step 4 is the actual digestion and getting into the cell.
Right. Pancreatic lipase does the heavy lifting, cleaving the triglycerides. Then the micelles, our taxis, diffuse down to the enterocyte brush border where their contents get released and absorbed into the cell. But here's a critical detail for learners.
What's that?
The bile salts themselves, the taxis, they are largely not absorbed here in the jejunum. They stay behind in the lumen.
And why is that so important? Why do they wait?
Because the body has spent a huge amount of energy making them, and they're needed further downstream to keep transporting fat. It's all part of the enterohepatic circulation. If we absorb them too early, we'd run out, and that would be metabolically just incredibly expensive.
A very good point. Okay, so step 5. Reassembly inside the cell.
Once inside the enterocyte, those fatty components are reformed back into triglycerides. Then they're packaged up with cholesterol and specific epiproteins into much, much bigger complexes, the chylomicrons.
And finally, step 6 is transport. These chylomicrons, which we can anchor as the freighters, they can't just go into the bloodstream like sugar or amino acids, can they?
They're simply too big. If they tried to enter the portal capillaries, they'd just clog them up. So instead, they get exocytosed into the more permeable mesenteric lymphatics.
Ah, so they bypass the liver initially.
They do. They travel up through the lymphatic system to the thoracic duct and then enter the systemic circulation. And those bile salts we left behind, they get actively resorbed way down in the terminal ileum and recycled back to the liver, completing that whole enterohepatic loop.
That detailed process is just fundamental. Protein absorption seems a bit more direct by comparison.
It's certainly less complicated logistically. Pepsin starts the job in the stomach, but the real work is done by pancreatic proteases, again, stimulated by CCK. The key here is an activation cascade.
Right.
Trypsinogen is activated by a brush border enzyme called enterokinase, becoming active trypsin. Then trypsin becomes the master activator for all the other proenzymes.
So it sets off a chain reaction.
A huge enzymatic attack on the proteins. And the final products get actively transported into the cells and then into the portal circulation.
All of this complex work needs exquisite timing. So let's talk about the master controller, the gut's own neural system.
We're talking about the enteric nervous system, the ENS. It's often called the gut's own brain.
It's that complex.
Oh, yeah. It contains as many neurons as the entire spinal cord. It functions almost completely autonomously, though it's modulated by the central autonomic nervous system. It's arranged into 2 key layers, or plexuses.
The myenteric and submucosal.
Exactly. The myenteric, or Auerbach's plexus, is mostly about motor control, muscle contraction. The submucosal, or Meissner's plexus, regulates secretion, absorption, and local blood flow.
And what actually starts the basic rhythm of peristalsis? Where did that come from?
That rhythm originates from the interstitial cells of Cajal, or ICCs. You should think of these as the pacemakers of the gut. They spontaneously generate these slow waves of electrical activity, setting the baseline frequency of contraction.
So the nervous system can change the strength, but not the frequency.
Precisely. The ANS can make the contraction stronger or weaker, but the ICC set the beat.
So that's for everyday digestion after a meal. But what about when the gut is resting? It has a kind of cleaning cycle, doesn't it?
It does. That's the migrating motor complex, the MMC. This is a powerful, coordinated wave of contraction that sweeps from the stomach all the way to the ileum.
And this happens when you're fasting.
Roughly every 90 minutes during the fasting state. Its whole purpose is to sweep the intestine clean. It flushes out residual food, debris, and, really importantly, excessive bacteria from the small bowel into the colon. The moment you eat, the MMC stops and normal peristalsis takes over.
Speaking of bacteria, that's a perfect transition to the intestinal microbiota. This has just dominated GI research for the last decade. The anchor for the scale of this is the 100-fold genome.
It's truly mind-boggling. We estimate there are 10-14 microbial residents living in our bodies, mostly in the colon. If you count up their genes, they outnumber our own human genome by at least 100-fold.
It's not just colonization, then. It's a symbiotic organ.
Completely. It's involved in synthesizing vitamins we need, like K and B vitamins, fermenting complex carbs we can't digest, and even training our immune system from birth.
So what's the clinical relevance here? Why is it so important for a student to grasp this concept?
Because when this delicate ecosystem gets thrown out of balance, a state we call dysbiosis, it's being linked to a huge range of diseases. In the GI tract, there are strong links to IBD, C. diff infection, colorectal cancer.
It goes beyond the gut.
It extends systemically to metabolic disorders like diabetes and obesity, cardiovascular health, and even to the gut-brain axis, where dysbiosis is linked to things like depression and anxiety. For any medical learner, seeing the microbiota as a key player, not just a passenger, is, well, it's essential for the future of medicine.
Okay, let's transition from the microscopic systems to the patient in front of us. When we approach a GI patient, we really have to avoid tunnel vision. The gut often expresses its problems in places you wouldn't expect.
Precisely. A good GI exam starts well outside the abdomen. Just looking at the skin and nutritional status gives you immediate clues. For example, clubbing of the fingertips. That often signals a chronic inflammatory state.
Like malabsorption, liver disease, or IBD.
Exactly. And there are specific skin findings that should just scream IBD at you.
You're talking about erythema nodosum and pyoderma gangrenosum?
Yes. Area nodosum, those tender red nodules on the shins, or the much nastier pyoderma gangrenosum ulcers. Finding those demands a workup for inflammatory bowel disease.
And what about nutritional signs in the mouth?
Things like atrophic glossitis, that smooth, beefy red tongue, or angular stomatitis, the cracks at the corner of the mouth, are classic signs of B12 or iron deficiency, pointing straight to malabsorption.
And there's one particularly ominous sign in the neck.
Virchow's gland, an enlarged, hard, non-tender supraclavicular lymph node. That is a sign of advanced, disseminated malignancy, and it strongly suggests advanced gastric cancer. Finding that, it just elevates the urgency immediately.
So once we actually get to the abdomen, let's just quickly run through the proper sequence.
Always follow the sequence to avoid missing things. Observe first for distension, scars, movement. Then auscultate, listen for bowel sounds before you start poking around.
To avoid artificially stimulating them.
Right. Then percuss to map out organs and check for fluid or gas. And only then do you palpate, checking for tenderness, masses, and organomegaly.
Now, one of the most common presentations is just generalized abdominal distension. The differential is huge, but we have a great mnemonic for this. The 5 F's of distension.
This is a high-yield clinical anchor. The 5 F's.
1. Fat, just obesity.
2. Fluid, meaning ascites, or sometimes blood.
3. Flatus, which is gas from an obstruction or ileus.
4. Feces, from severe constipation.
And 5. Fetus, pregnancy.
And that simple list forces you to consider mechanical issues, volume issues, constitutional causes, and the reproductive tract. It's a great safety net.
Okay, let's tackle the high-stakes presentation. Acute GI bleeding. This is still the most common GI emergency.
It's a huge cause of morbidity and mortality. In the UK, the mortality rate for admitted patients is still around 10%, even with all our modern techniques. Recognizing severity quickly is everything.
How do we get those first clues to localize the bleed?
From the appearance of what's coming out. Hematemesis vomiting blood is classic for an upper GI bleed. If it's bright red, that suggests a rapid ongoing bleed. If it looks like coffee grounds, that means the blood has sat in the stomach and been altered by acid.
And on the other end?
You have maliina, those black, tarry, foul-smelling stools. That's altered blood and almost always means an upper GI source because it needs time to transit through the gut.
But sometimes a massive upper GI bleed can present with red blood per rectum, can't it?
It can, and that's a very dangerous sign. If someone is bleeding massively from, say, Esophageal varices, the volume and speed can be so great that it just rushes through the system, presenting as maroon or bright red stool. So you always have to assess the patient's hemodynamic status first, regardless of the blood color.
Since time is so critical, we need to risk stratify patients immediately, even before an endoscopy.
That's where the Blatchford score comes in. It's calculated right at admission using things like BUN, hemoglobin, blood pressure, heart rate.
Things you know right away.
Exactly. And a low score, say 2 or less, predicts a very low risk of needing intervention. It can help you safely manage a patient as an outpatient.
Okay, let's anchor the immediate life-saving steps with the 4 steps of emergency management. This has to be automatic.
Step 1, 5E access. The absolute priority is volume resuscitation. You need 2 large-bore intravenous cannulae.
Why 2?
Because if the patient crashes, you need 1 line for fluids and blood and another for giving drugs at the same time. You can't be fumbling for a second line when they're hypotensive.
Step 2, initial assessment.
Quickly check their circulatory status, look for signs of chronic liver disease, and identify major comorbidities like heart disease that change your transfusion threshold.
Step 3, investigations.
Get the bloods, including a full blood count. But here is a critical, high-yield caveat you must remember. The hemoglobin might be normal initially.
Why is that?
Because the patient is losing whole blood. They haven't had time to pull fluid from the interstitial space to dilute what's left. The true anemia only shows up after a few hours or after you give them fluids. So a normal initial HB can be falsely reassuring.
That is such a key clinical pearl. And step 4 is resuscitation.
Correct, the hypovolemia. Start with crystalloid boluses. For blood, we're generally restrictive. The threshold is usually an HB of less than 70 GL. But you transfuse earlier if they have ongoing ischemia or are very unstable.
Perfect. Moving on to other common complaints, vomiting and dysphagia.
Vomiting is a very complex, coordinated reflex. The diaphragm and abdominal muscles contract, the LES relaxes. It's a forceful expulsion. The key skill is to distinguish that from passive regurgitation, which suggests more of an esophageal obstruction or motility issue.
And with dysphagia difficulty, swallowing localization is everything.
Precisely. You have to figure out if it's oropharyngeal, meaning a problem initiating the swallow, which often causes choking and aspiration.
Like in a stroke patient?
Right. Or if it's esophageal, which feels like food getting stuck lower down. That suggests either a mechanical blockage like a tumor or stricture, or a motility disorder. The history is key.
Our last presenting problem here is malabsorption and weight loss. If a patient has chronic diarrhea and is losing weight, how should we categorize the possibilities?
You classify the causes based on where the process fails. Is it luminal failure, a problem with digestion, like not enough pancreatic enzymes?
Or is it mucosal failure?
The most common type. Damage to the gut lining, like in celiac disease, so you can't absorb things. Or, finally, is it post-mucosal failure, a problem with transport after absorption, usually a lymphatic blockage?
And when a patient presents with unexplained weight loss, what's the clinical trap?
The trap is assuming it's a GI cause right away. The differential for pathological weight loss is massive. It spans psychiatric illness, chronic infections like TB, advanced malignancy anywhere in the body, and of course the specific GI causes. You have to keep a very open mind.
So we have our clinical picture. Now we need the tools to look inside and confirm what's going on. The GI toolkit is huge, covering both structure and function.
And we start with the basics. Even with CT and MRI, plain X-rays are still essential in acute care.
They're absolutely non-negotiable for an acute bowel obstruction. What are we looking for?
You're looking for dilated loops of bowel, often stacked on top of each other, and you might see air fluid levels on an erect film. But the critical can't-miss anchor for a perforation is free air under the diaphragm.
Air that has escaped the gut.
Exactly. It collects between the liver and the diaphragm. Seeing that means an urgent call to the surgeons.
Beyond plain films, we have contrast studies.
Right, using barium or water-soluble contrast. Barium gives beautiful mucosal detail, great for small ulcers, but you absolutely avoid it if you suspect an obstruction because it can set like concrete.
So you use water-soluble contrast if there's a risk of perforation.
Yes, because it's much safer if it leaks into the peritoneum. It's also what we use to opacify the bowel for CT scanning.
Okay, let's move to the advanced cross-sectional imaging. How should a learner decide between CT and MRI?
That's a great question. You can think of CT as the workhorse. It's fast, widely available, and it's the best for looking for liver mets, staging many cancers, and finding acute complications like an abscess.
And MRI.
MRI gives you superior soft tissue contrast and no radiation, so it's become the preferred choice for detailed analysis of certain things. Specifically, MR enterography is the gold standard for looking at the small bowel in Crohn's disease.
And also for pelvic disease like fistulae.
And pelvic and perianal disease, exactly. And for the biliary tree, an MRCP is now the diagnostic test of choice, replacing diagnostic ERCP.
And then there's endoscopic ultrasound, or EUS, which kind of merges endoscopy and imaging.
Yeah.
What's its unique role?
EUS is unique because the ultrasound probe is right on the tick of the endoscope. This lets you visualize through the wall of the GI tract into the surrounding tissues, lymph nodes, and organs like the pancreas.
Which is critical for staging.
Indispensable for T-staging, determining the depth of tumor invasion for esophageal and pancreatic cancers. And it lets you do a fine needle aspiration or biopsy right through the gut wall.
Okay, let's look at the endoscopy hierarchy. Standard scopes get you the duodenum and the colon. But what if the problem is deep in the small bowel?
Right, so if we suspect pathology in that vast middle section of the small bowel, we first turn to capsule endoscopy.
Which is an amazing diagnostic tool, but it's just a camera. It can't treat anything.
Correct, purely diagnostic. The patient swallows the capsule, it takes thousands of pictures. If it finds something significant, like a bleeding point, the next step is often enteroscopy.
And that's the therapeutic procedure.
Yes. That's a specialized scope, often using a double balloon system that can be advanced much deeper to actually treat the lesion, clip it, tattoo it for surgery, or biopsy it.
Finally, we have ERCP. How should a learner clearly separate this from MRCP or EUS?
ERCP, endoscopic retrograde cholangiopancreatography, must be anchored primarily as a therapeutic procedure. It involves cannulating the bile and pancreatic ducts. You use it to treat things, remove stones, place stents that you've already found using a non-invasive test like an MRCP. If you only want a picture, you get an MRCP first.
Let's pivot to tests of function and infection, starting with H. pylori.
The non-invasive gold standard for active infection is the urea breath test. It relies on the fact that H. pylori produces a ton of an enzyme called urease.
How does it work?
The patient drinks C13 labeled urea. If the bacteria are there, their urease splits it into ammonia and C13 labeled carbon dioxide. You then measure that C13CO2 in the patient's breath. An elevated level confirms active infection.
Beautifully simple mechanism. What's the other main non-invasive option?
The fecal antigen test. It's highly specific, often cheaper, and an excellent alternative, especially for confirming that you've successfully eradicated the bacteria after treatment.
We also use breath tests for functional issues like lactose intolerance.
Yes, the hydrogen breath tests. The principle is that if a sugar like lactose is malabsorbed, it gets to the colon undigested. The colonic bacteria then ferment it, producing hydrogen gas.
Which you measure in the breath.
Exactly.
Yeah.
That hydrogen is absorbed into the blood and measured. An abnormally early rise in hydrogen after drinking, say, lactulose, suggests that fermentation is happening in the small bowel, which points to small intestinal bacterial overgrowth, or SIBO.
In rounding out these functional tests, how do we diagnose bile acid diarrhea?
It's often diagnosed using the Sechcat test. This uses a radio-labeled synthetic bile acid. If the body retains less than 5% of it after 7 days, that confirms significant bile acid malabsorption.
But that involves radiation.
It does. So increasingly, we're using non-invasive blood markers like an elevated serum $7 alpha-hydroxycholesterol. High levels suggest the liver is working overtime to make new bile acids because so many are being lost, which strongly correlates with BAD.
We've got the background and the tools. Let's apply it to specific diseases, starting with the very common gastroesophageal reflux disease, or GERD. The anchor here is simple: the leaky valve theory.
GERD is fundamentally a failure of the lower esophageal sphincter, the LES, to stop the backflow of acidic stomach contents. And it's usually not just one thing, it's a failure of multiple factors.
What are the big contributing factors that make that valve leaky?
A hiatus hernia is probably the biggest mechanical factor. When part of the stomach slides up above the diaphragm, it messes up the anatomy that normally keeps the LES tight.
And what else?
Other key factors are defective esophageal clearance. So acid stays in contact with the lining for longer delayed gastric emptying, and anything that increases intra-abdominal pressure.
Like obesity or pregnancy.
Exactly.
For management, the step-down approach using PPIs is standard.
Right. We start with lifestyle changes and antacids, then escalate to a full-dose proton pump inhibitor to get control, and then try to step down to the lowest effective maintenance dose. They're incredibly effective because they block that final common pathway, the proton pump itself.
But they're not without risk, especially long-term. What are the key long-term dangers we need to counsel patients about?
That's a critical point because they are so overused. The key risks are related to reduced absorption. You get reduced absorption of vitamin B12, iron, and magnesium.
And infections.
Yes, you also increase the risk of enteric infections like Salmonella and Campylobacter and possibly C. diff because you've removed that protective acid barrier. And finally, there's a risk of acid rebound when you try to stop them, which makes it hard to get off the medication.
And the most serious long-term consequence of untreated GERD is Barrett's esophagus.
Barrett's is the body's adaptive but dangerous response to chronic acid damage. The normal squamous lining of the lower esophagus gets replaced by a specialized columnar mucosa, a type of intestinal metaplasia. This is a pre-malignant condition that increases the risk of esophageal adenocarcinoma.
The related but very different condition is eosinophilic esophagitis, or EOE. We anchor this as the allergic esophagus.
The analogy works really well because EOE is an allergic or antigen-driven disorder. It's characterized by a dense infiltration of eosinophils in the esophageal lining, and it's often seen in people with other atopic diseases like asthma or eczema.
And the presentation is often different from classic GE.
It is. Adults typically present with more mechanical symptoms: chronic dysphagia, difficulty swallowing, or sometimes an acute food bolus obstruction where food actually gets stuck.
And how do we confirm the diagnosis?
It requires an endoscopy with multiple biopsies from different parts of the esophagus, looking for a density of 15 or more eosinophils per high-powered field.
And what's the anchor for the initial treatment strategy?
You must always start with an empirical 8-week trial of a high-dose PPI. This identifies a significant subgroup of patients with PPI-responsive EOE and helps rule out GERD. If they don't respond, then you move to topical glucocorticoids, like swallowed fluticasone or budesonide.
Okay, moving to the stomach and peptic ulcer disease, a classic pathology driven by two main culprits.
PUD is an imbalance between protective factors, like mucus, and aggressive factors, like acid. The etiology is dominated by Ater-Albari infection, the most common cause, and NSAIDs. Smoking is a major risk factor that also impairs healing.
Let's talk about H. pylori's virulence. It's not just sitting there, it's actively messing with the host cells.
It's a very sophisticated pathogen. It has a molecular syringe, the KG gene product, which it uses to inject a protein directly into the epithelial cells. This disrupts cell signaling and promotes chronic inflammation.
Now, what about the Vacay toxin?
Vate is a pore-forming protein that increases cell permeability and also suppresses the local immune response, which helps the bacteria survive. Together, these factors cause chronic inflammation, cell death, and ultimately an ulcer.
What's the key clinical pitfall when diagnosing PUD, especially in older patients?
The pitfall is relying on classic symptoms. KIU can be completely silent, especially in the elderly or those on NSAIDs. They may present for the first time only when a major complication happens, like a massive bleed or a perforation.
Once we confirm H. pylori, how do we treat it?
Eradication therapy. It's a high-dose PPI twice a day for 7 to 14 days, combined with 2 antibiotics, usually clarithromycin and amoxicillin. Now let's anchor the 2 major life-threatening complications of PUD.
First up, perforation. What does that look like?
It's sudden and catastrophic. The patient gets sudden, severe, generalized abdominal pain. On exam, the abdomen is classically described as board-like rigidity from the generalized peritonitis.
And the diagnostic test.
An erect chest X-ray. In over half the cases, it will show free air under the diaphragm. This is a surgical emergency with a high mortality rate.
The second complication is gastric outlet obstruction.
This is usually more chronic, caused by scarring from an ulcer near the pylorus. Patients present with vomiting, often of food eaten more than 24 hours previously. On exam, a succussion splash heard more than 4 hours after a meal is a highly suggestive sign.
And the management.
Aggressive NG tube decompression to empty the stomach, IV fluids to correct the severe electrolyte problems, and then definitive treatment, which could be endoscopic dilation or surgery.
Our deep dive continues into the small bowel, focusing on key malabsorption disorders. Let's start with the classic, celiac disease.
Celiac disease is a chronic inflammatory disorder of the small intestine. It's triggered by gluten in genetically susceptible people, those with the HLA-DQ2 or HLA-DQ8 alleles. The immune system basically attacks the small bowel lining in response to gluten.
The pathology is the key anchor here. What are the three classic histological features on biopsy?
The definitive triad is 1. Villus atrophy, so the absorptive surface area is flattened and massively reduced.
Clue.
2. Crypt hyperplasia, where the glands at the base of the villi are over-proliferating to try and repair the damage. And 3. A dense infiltration of intraepithelial lymphocytes.
And what's the high-yield screening tool we use before even thinking about a biopsy?
The primary screening test is measuring the tissue transglutaminase, or TTG, antibody, which is an IgA antibody. You often check total IgA at the same time just to make sure the person isn't IgA deficient, which would give you a false negative.
And why do we care so much about diagnosing this? What are the major long-term complications?
2 big ones. First, metabolic bone disease, so osteoporosis or osteomalacia, from chronic malabsorption of calcium and vitamin D. Second, and more ominously, there's an increased risk of specific lymphomas, particularly enteropathy-associated T-cell lymphoma, or EATL.
Okay, moving to 2 other common malabsorption issues. Small intestinal bacterial overgrowth, SIBO, and bile acid diarrhea, BAD.
SIBO is exactly what it sounds like. Too many bacteria in the small intestine. They get there because of impaired clearance, maybe from a stricture or a motility disorder. These bacteria then deconjugate bile acids and consume nutrients like B12 before we can.
How do we diagnose it non-invasively?
With the glucose or lactulose hydrogen breath test, the key finding is an early rise in hydrogen gas, usually within 90 minutes. That tells you fermentation is happening in the small bowel where it shouldn't be. Treatment is usually a 2-week course of an antibiotic like rifaximin.
And for BD, how is it classified and treated?
Bile acid diarrhea causes a secretory diarrhea because excess bile salts get to the colon and irritate it. It can be type 1, which is secondary to terminal ileal disease like Crohn's, or type 2, which is idiopathic.
And the treatment targets that mechanism.
Exactly. You use bile acid sequestrants like cholestyramine or cholecalciferol. They bind the excess bile salts in the lumen, neutralizing them before they can cause diarrhea.
Let's turn our attention now to the colon and colorectal cancer. First, we need to distinguish between polyps that are dangerous and those that aren't.
Right. Non-neoplastic polyps, like hyperplastic polyps, are generally benign. The concern is with neoplastic polyps, which are adenomas. These are the true precursors to most colorectal cancers. The sessile serrated lesion is another important high-risk precursor, often found flat and on the right side of the colon.
This leads us to the 2 major pathways of cancer development.
Understanding these is key. First is the classical adenoma-carcinoma pathway. This is a slow, sequential accumulation of mutations over 5 to 10 years, often starting with a hit to the APC gene. This is how most sporadic cancers develop.
And the second pathway?
The serrated neoplasia pathway. This involves those sessile serrated lesions, often has a BRAF gene mutation, and these tumors can grow faster and are often found in the proximal colon, making them harder to detect.
To anchor the hereditary risks, we have to contrast the 2 classic syndromes. First, FAP.
Familial adenomatous polyposis, FAP. The anchor here is volume. Patients develop hundreds, sometimes thousands, of adenomatous polyps because of a germline mutation in the APC gene. The lifetime risk of cancer is nearly 100%.
So the treatment is prophylactic surgery.
Prophylactic total proctocolectomy, yes. And screening for family members has to start really early, around 13 or 14 years old.
And the second syndrome is Lynch syndrome.
Right, hereditary non-polyposis colorectal cancer, or HNPC Clinch syndrome. This is caused by defects in DNA mismatch repair genes. Patients have a very high lifetime risk of cancer, up to 80%, but with fewer polyps than FAP.
And a high risk of other cancers, too.
A very high risk of extracolonic cancers, especially endometrial and ovarian cancer. The diagnosis is increasingly molecular, looking for evidence of microsatellite instability, or MSI.
Now we enter section 6, inflammatory bowel disease. For any medical learner, mastering the fundamental differences between ulcerative colitis and Crohn's disease is non-negotiable. This is the great IBD divide.
The differences are profound. It's the anatomical distribution and the depth of the inflammation that really dictates everything. The symptoms, the complications, the treatment.
Okay, so let's start with the defining features of ulcerative colitis.
Ulcerative colitis is inflammation that is strictly limited to the colon and rectum. It always involves the rectum and spreads proximally in a continuous fashion. Pathologically, the inflammation is mucosal only,
Just the inner lining.
just the lining, which is why the main symptom is bloody diarrhea and why you don't typically see things like strictures or fistulae. And paradoxically, it's associated with non-smokers or ex-smokers.
In stark contrast, what defines Crohn's disease?
Crohn's disease can affect any part of the GI tract, from mouth to anus. The key pathological difference is that the inflammation is transmural. It goes through the entire thickness of the bowel wall.
And that's why you get those different complications.
That's exactly why you get strictures, abscesses, and fistulae. The distribution is patchy, with normal areas of bowel in between diseased areas, the so-called skip lesions. And it's strongly associated with smokers.
The core pathogenesis for both seems to be a dysregulated immune response to gut bacteria in people who are genetically susceptible.
Exactly. Genetics are a huge part of it. NOD2 mutations, for example, are the strongest genetic risk for Crohn's. But ultimately, some trigger causes a breakdown of tolerance, leading to this chronic excessive inflammation driven by cytokines like TNF-alpha.
Let's focus on a key complication of UC, toxic megacolon.
A life-threatening emergency.
What are the diagnostic criteria?
It's a clinical picture of systemic toxicity fever, tachycardia, high white cell count combined with radiological evidence. The anchor is a transverse colon diameter greater than 6 centimeters on an abdominal X-ray. This indicates near paralysis of the colon and a very high risk of perforation. It's a surgical emergency.
For routine monitoring and for telling IBD apart from something like IBS, we have a great non-invasive test.
Fecal calprotectin. This is a protein that's released by neutrophils during inflammation. Its level in the stool correlates beautifully with mucosal inflammation.
So it's useful for diagnosis and monitoring.
Essential for both. It helps distinguish IBD from IBS, it helps monitor disease activity, and it can even predict relapse. It's often a better marker of gut inflammation than systemic markers like CRP.
And for Crohn's, mapping out the disease is vital.
Right, and that's where MRI enterography comes back in. It's critical for assessing the transmural extent of the disease, finding fistulae, and very importantly, trying to differentiate between an inflammatory stricture that might respond to medication and a fibrotic one that will need surgery.
Okay, let's move to medical management. First line for mild to moderate UC.
5-ASAs, or 5-aminosalicylates, they're topically acting anti-inflammatory agents. Their efficacy is all about getting the drug to the site of inflammation, so they have different delivery systems to release in the colon.
When we use steroids?
Corticosteroids are powerful drugs reserved for inducing remission during an acute flare. They are absolutely not for long-term maintenance because of their severe side effects. Once the flare is controlled, you have to taper them off.
The next step up is immunomodulators, like azathioprine. These require some careful planning.
They do. The anchor here is thiopurine metabolism. These are prodrugs that get metabolized to the active TGNs. The enzyme that breaks them down, TPMT, has wide genetic variation. So before you start, you must check the patient's TPMT activity to avoid potentially fatal myelosuppression.
And they're slow to work.
Very slow. They take about 6 weeks to become effective, so you can't use them to treat an acute flare.
Finally, we get to the biologics, the highly targeted therapies. Let's run through the 4 major classes.
First, the anti-TNF-alpha antibodies, like infliximab. They neutralize the key pro-inflammatory cytokine. Because TNF-alpha is important for fighting infection, you have to screen for latent tuberculosis and hepatitis before starting.
Second class.
Anti-integrin antibodies, like vedolizumab. These block inflammatory cells from getting into the gut wall. Their big advantage is that they are relatively gut-specific, so less systemic immune suppression.
Third.
Anti-P40 antibodies like ustekinumab. This blocks 2 other key cytokines, IL-12 and IL-23, which are central to Crohn's pathology.
And the newest class, the oral agents.
The JA inhibitors, like tofacitinib. This is a small molecule taken orally that blocks cytokine signaling inside the cell. A high-yield point here is the increased risk of herpes zoster, or shingles, so vaccination is recommended before you start.
And given how complex and expensive these are, we need to monitor them. That's therapeutic drug monitoring, or TDM.
TDM is essential. We measure the drug level and the level of anti-drug antibodies. This helps us figure out why a drug has stopped working. Is the dose too low, or has the patient developed antibodies that are neutralizing the drug? It allows for personalized precision medicine.
We're moving to our final section now, the pancreas. Acute pancreatitis is a severe high-mortality event. Let's nail down that classic presentation.
It's intense, severe, constant upper abdominal pain that often radiates straight through to the back. There's marked epigastric tenderness, but, and this is a key subtlety, in the early stages, there's usually no board-like rigidity.
Why not?
Because the pancreas is a retroperitoneal organ, so the inflammation doesn't immediately irritate the sensitive parietal peritoneum like a perforated ulcer does.
For diagnosis, which enzyme do we prefer, amylase or lipase?
Serum lipase is generally preferable. It's more specific to the pancreas, and it stays elevated for longer than amylase, which can be high for lots of other reasons.
Once it's diagnosed, predicting severity is the next critical task.
Yes, and we use scoring systems for that. But some high-yield indicators of a severe course are things like a C-reactive protein, a CRP greater than 150 mL within the first 48 hours, or any sign of persistent organ failure.
The management is all about resuscitation and pain control. What's the rationale for early enteral feeding?
So management starts with aggressive IV fluids and opiate analgesia. The reason for early enteral feeding in severe cases is to maintain the integrity of the gut mucosal barrier. Feeding the gut prevents bacterial translocation from the gut into the bloodstream, which reduces the risk of sepsis and multi-organ failure.
And what's the rule on antibiotics?
Prophylactic antibiotics are not indicated. They are reserved only for cases where you have confirmed or highly suspected infected necrosis.
And for gallstone pancreatitis, there's a critical timeline to prevent it from happening again.
Absolutely. For patients whose pancreatitis was caused by gallstones, the definitive treatment is cholecystectomy, which must be performed within 2 weeks of resolution of the attack to prevent a recurrence.
Okay, moving to the chronic pain spectrum and functional GI disorders, starting with irritable bowel syndrome, or IBS.
IBS is a clinical diagnosis based on the Roman-Via criteria. It's recurrent abdominal pain associated with a change in bowel habit, and crucially, the absence of alarm symptoms like weight loss or bleeding.
The pathophysiology gives us 3 clear anchors for how we treat it.
Exactly. One is visceral hypersensitivity, which explains why low-dose tricyclic antidepressants can help with the pain. 2 is dysbiosis, an altered microbiota, which is why some patients respond to certain antibiotics or probiotics. And 3 is dietary factors, specifically FODMAPs, which is why a low FODMA diet is a key management step.
And for functional dyspepsia, which can feel a bit like gastroparesis.
We target treatment to the subtype. If it's postprandial distress syndrome with early satiety and fullness, we use prokinetics to speed up gastric emptying. If it's epigastric pain syndrome with dominant pain or burning, we focus on acid suppression or TCAs.
Our final topic is constipation, specifically separating simple causes from a mechanical defect.
Chronic constipation can be from lack of fiber, or it can be a motility issue, or critically, a defecation disorder.
Let's talk about the specific mechanical problem of dysenergic defecation.
This is a failure of coordination. When the patient tries to defecate, they inappropriately contract their pelvic floor muscles instead of relaxing them. This creates a functional obstruction. For this specific mechanical problem, biofeedback therapy is the highly effective first-line treatment.
And finally, we have to mention the critical congenital cause of constipation.
That would be Hirschsprung's disease. This is a congenital absence of ganglion cells in a segment of the distal colon. This ganglionic segment remains permanently constricted, causing a failure of the internal anal sphincter to relax and leading to chronic obstruction and megacolon. So, we have covered a vast amount of territory today, from the molecular level right up to complex disease management. Let's quickly anchor those key concepts one last time. For foundational function, you have to remember the acid-secreting proton pump and the incredible logistics of the Micelle taxi service.
And when you're assessing a sick patient, always use that systematic approach. The 5 F's for a distended abdomen, and the 4 steps of emergency management for a GI bleed.
In pathology, anchor those essential differences: the mucosal, continuous UC versus the transmural, patchy Crohn's disease.
And don't forget the utility of our diagnostic tools, like EUS for deep staging, and the power of non-invasive breath tests for everything from H. pylori to SIBO. Finally, always think about complications, like free air on a chest x-ray meaning perforation, or that CRP greater than 150 in pancreatitis telling you this is severe.
This deep dive started with the incredible scale of the intestinal microbiota, those 1014 microbial residents that outnumber our own genome 100-fold. This is not just them living there, it's active metabolic and immunological regulation.
And the emerging picture is that dysbiosis, an imbalance in that ecosystem, is linked to systemic diseases, obesity, diabetes, even depression. We are just at the very beginning of understanding this.
So here's our final thought for you to carry forward. The GI tract is not just an organ system. It's an integrated ecosystem that influences our entire physiology. If we've already established that the microbiota can influence an organ as complex and distant as the brain, what other major systemic diseases, autoimmune disorders, neurodegenerative conditions, maybe even aspects of aging might one day be managed or cured not by targeting that distant organ, but by simply restoring health and balance to that 25-foot tube?
The next great leap in systemic medicine might be rooted right there in the gut.